Hey everybody, welcome to the episode of the Med List today with Donna and I. Really excited, Donna. I mean, I think that it's invigorating for a kid that grew up on the reservation to have other Indigenous colleagues on and get to talk to them, and really appreciate you reaching out and connecting with this group to bring in just conversations that I don't think are showcased often enough. They don't get enough airtime, and oftentimes I feel like there's this thought that culture is it's individualized, right? You take it and you put it in a bag and you wrap it up and you put it over in the corner, and that's what you just think about differently than other people do, as opposed to being able to benefit from it, right? To be able to learn from each other, to be able to grow within each other and see that there are different perspectives, and sometimes those perspectives can be extremely beneficial for a broader group than just the way that you were raised or kind of how you live. So really excited to bring Amber and Amy on today with us.
Yeah, absolutely. And for me, it's going to be a whole new world for me in regards to not being of Indigenous people descent. So I'm excited to learn so much more and really probably change some of the perceptions I have too, right? So I'm looking forward to being that for others.
All right, well, let's do it.
Yeah, so thank you so much for being with us. Today we have Amber Rubin and Amy Lamb with us. And I just want to do a quick little introduction of each. I'm going to let them elaborate a little bit more as they share their experiences with us. But first we have Amber Rubin, and she is an Inuvialuit, I hope I have that right, pharmacist. She's an advocate for Indigenous health equity, and she's the chair of the Indigenous Working Group at the Canadian Deprescribing Network. And this is basically how we learned about both of you, is through the Canadian Deprescribing Network and the wonderful work that you're doing with this Indigenous Working Group. So really excited to hear more about that. And then we have Amy Lamb as well, and she is a Métis pharmacist and woman, and she is part of the she is the executive director of the Indigenous Pharmacy Professionals of Canada. So I'm just so excited to learn from both of you and how you've worked in really helping to identify the needs of Indigenous peoples and the Indigenous community that you both have lived and worked in. And I think it's just wonderful what we're going to be learning about, and just what you bring to not only your profession, but to your communities themselves. So thank you for being with us.
Happy to be here. Thanks for having us.
Thank you. So I really just want to get started. If you could first tell us a little bit more about you and your background in pharmacy, and then this, if you will, passion of staying within your communities and helping the Indigenous peoples that you are also a part of.
I'll go ahead. My name is Amber Rubin. And so Rubin is a family name from around Paulatuck, Northwest Territories. And our original family name would have been Enguk. It would have been changed by settlers who've arrived and found that difficult to say. My Inuvialuit name is Nauyuk, and that's after my great-grandmother. And so in traditional Inuit naming, you're named after a person, and you are to capture and emulate that person as you live your life. And so I'm named after my great-grandmother that way. I was born and raised in Fort Smith, Northwest Territories, so a far distance from my dad's Inuvialuit homelands because of colonization. He attended residential school starting when he was about 6 years old, and he didn't ever live at home again. So that really severed a lot of ties to family, land, community, and traditional ways of knowing. My mom is settler family from central Alberta, and her family moved north, and so she met my dad there. And so my sister and I were raised in a community that had a lot of First Nations folks in it, First Nations and Métis. And so even though there was a huge distance from my Inuvialuit family, I certainly grew up with a lot of folks who were Dene and Cree and Métis. I ended up going on becoming a pharmacist, practiced for about 17 years within a hospital setting, And then a few years ago, stepped back from that role to be a master's student and also to take on further roles within this realm of advocacy in Indigenous health. And so I am now a consultant for Indigenous health equity and reconciliation within my organization. I'm on the executive committee for the Canadian Medication Appropriateness and Deprescribing Network, and also on the board of directors for the Indigenous Pharmacy Professionals of Canada with Amy. And so that's a little bit about me, and I'll turn it over to Amy.
Thanks,
Hello,
Amber.
everyone. My name is Amy Lamb. I am, as indicated, the Executive Director of the Indigenous Pharmacy Professionals of Canada, which is an association of First Nations, Métis, and Inuit, which are the three nationally identified Indigenous groups in Canada. And we represent pharmacists, pharmacy technicians, pharmacy assistants, and pharmacy students that have proof of that ancestry. I am a woman with Métis ancestry and a member of Métis Nation Saskatchewan. For those that are unfamiliar, Métis ancestry is mixed ancestry. It is more complex than just 50% First Nations, 50% settlers. These are traditional and very culturally specific communities that bridged those worlds when Canada's population was first settling. And so there are historic Métis settlements, and those who are of Métis ancestry are associated with those historic settlements, as my family is. And so we have years of that culture embedded in who we were, and like many Indigenous peoples in Canada, a disruption of our access to culture in most recent years due to some cultural genocidal practices and some embedding of structural and social harms, particularly where poverty seems to take away the storyline of your family. But as those that are Indigenous commonly are, well, we maintained a connection and a deep connection to the land. And I've got a grandmother space that I think of in many ways as a teacher and healer in my story. And my own Métis grandmother was the inspiration for joining the profession of some sort of healthcare, which ended up being pharmacy practice. Honestly, just knowing how much I loved and respected my elders and wanted to be one who delivers care. And so within the past 3 years, I have worked in Indigenous health advocacy in a very formal way. And through this role with the IPPC, I have a background as a community pharmacist for over 10 years now, practicing and traveling to remote and sometimes fly in Indigenous communities, First Nations communities here in Treaty 6 territory, of which I am practicing within. And it was at that time that I recognized the immense structural and systemic challenges facing Indigenous communities who didn't have equitable access to healthcare and pharmacy services in the same way that the other communities that I worked with had. And so at that time, we were just a small collection of like-minded and similar professional and diverse ancestries meeting. And we've had the opportunity to grow into both a community, but also a movement that's really driving Indigenous health equity, but also embedding some of that indigeneity in a way that recognizes as pharmacy professionals, we're trained in a Western pharmacy way. And so we need to look and understand and use that privileged space to use humility and create space for the voices of our communities and our knowledge keepers who have had their perspectives suppressed in the privileging of the development of healthcare in Canada. And so as part of that work, we now have a position on a Indigenization working group with the Canadian Association or Canadian Medication Appropriateness and Deprescribing Network, of which Amber is the chair of our group. And so she's also a board member on IPPC. And so we have this opportunity to work and share and to really, I think, help and discover and carry forward the perspectives of our communities in pharmacy practice and pharmacy sector, which of course is a major influence on the Canadian healthcare system.
Beautiful. Well, thank you so much for sharing both of your guys' backgrounds to a certain degree. And the one thing that I have to ask, I know we're really going to dive into some deep subjects here of decolonizing and indigenizing medication usage. But to get to that point, the curiosity, burning question I had before we jumped on screen, I saved it, was why pharmacy? Why did both of you think pharmacy was the right route for me to go personally, for my communities, for my future development as a human being? What was the reason for both of you? And we'll start same order. Amber, you first.
To be honest, the first time around, I decided not to go the pharmacy route. I found out you had to take inorganic chemistry in your undergrad. And so I rerouted. I did an undergrad in neuroscience, decided not to pursue graduate studies at that time, and realized I needed a career. But I had thought pharmacy the first time. And it was because of our community pharmacist in our community, town of 2,500 people, and people respected her and relied on her. We had locum physicians, and people really trusted the pharmacist we had. And so I saw such ability to create change and to have value for people in their health and wellness based on what I saw in her. I worked at the cash register in the community pharmacy in high school. And so it made quite an impact on me. And so that's why ultimately I chose this career.
Wow. I love it.
I knew it was going to be healthcare. My family and myself have navigated chronic illness, holistic unwell-being, and so like healing was important to me. And so as any young person, your ideology is I'm going to be a doctor one day. And to be perfectly honest, some of the chronic health conditions that I was navigating made me look at, I think sometimes the stressful requirements, the 12-hour days and the working of emergency room departments as a little bit inaccessible. And the other part of medical practice that was inaccessible to me was the cost. And pharmacy was pretty cheap to apply to. And so to be perfectly honest, I just applied because it was inexpensive, the application form at the very least. And then I spent that summer working in a pharmacy. And I speak commonly about how, particularly with the role of our organization trying to increase representation of Indigenous pharmacy professionals, I think there's a really huge misunderstanding about what a pharmacist does. And so once I stepped into those doors, once I had the opportunity, as Amber reflects upon, to see these caring professionals, and I'd always worked in like retail settings. I worked for sports stores and sold skis, and it was like, this is really that same feeling. Like someone's walking in the door, you're getting this chance to really casually engage with them. You know them more and more every time they step into the door. And there's actually, I think, almost a safer and more authentic engagement that folks have at the pharmacy counter than they do sometimes stepping into this very like formal appointment with another health professional. And honestly, I was hooked. I spent that summer like looking at all the medications and reading the indication on the back and going, wow, really? Like, this is so cool. And again, just being really inspired by, I think, how pharmacy practice has and continues to be fully rooted in community and very much an exemplary form of what community leadership looks like in business practice.
Wow, that's fantastic.
So if we can go back a little bit, you'd mentioned about the Canadian Deprescribing Network and the medication appropriateness, and just kind of the outside looking in, why is it that a working group was necessary? Or, was it decided that a working group is necessary in order to kind of, if you will, separate or find the needs, if you will, of the Indigenous communities? And so how does that, can you give us an example or examples of how that might be a little bit different, why a working group was necessary for that particular area?
Absolutely. I think CADEN, that's the Canadian Medication Appropriateness and Deprescribing Network. So CADEN's, a little bit of an easier mouthful, had set out to do some work with Indigenous community. They were established in 2015, and they hadn't really created any educational tools or done work with Indigenous community. And so there was a recognition that this needed to be done. And they had some very initial broad ideas about indigenizing and just taking tools that were already made and putting them out for Indigenous communities to assess. And then some academics in the world, in the field of pharmacy who've done work with First Nations said, what you really have to do is kind of take a pause and actually create relationships with First Nation, Métis, and Inuit communities. You have to go out and find out what this means to them. You have to have discussions. You have to listen with intent and work from there rather than bringing what's already been developed to communities. And so at that time, the working group was formed. And at that point, because we did have to develop a plan for the funder, it turned into being more of a creation of a 5-year action plan. And a 5-year action plan in terms of how we do this work in a good way, how we do it with respect, relevance, reciprocity, responsibility, and also while following the principles of OCAP, which is ownership, control, access, and possession of that information that Amy spoke to, I think, before the show, that we really need to respect that nations have this data and they have to remain the owners and holders of this knowledge. And so that's why the working group was formed. We really recognized that we needed to bring a few diverse people together to be able to inform how to do this in a good way.
You know, and I think what Amber's really speaking to is the need for authentic engagement as opposed to performism, and to understand the need for that in general really speaks to the transformation, the recognition of truth and of history that has occurred in Canada within the past, couple decades. There has been ongoing national reports led by Indigenous folks describing that there are atrocious health inequities. Indigenous peoples in the province of Alberta live an average of 19 years less than every other person in that province. And I think that there's some very clear values and outcomes that derive this. But those reports spoke of the truth. They spoke of the genocidal practices that occurred in colonization. And 10 years ago, the Truth and Reconciliation Commission of Canada listed calls to action, and many of those related to shifting and changing and transforming health systems. And within that time, there still has been fairly, I would say moderate momentum, but it took the discovery of nearly 10,000 graves of children at residential schools to really mobilize, I think, all Canadians to say that, holy smokes, like we have to do something. This isn't just like we'd like this. And I really like how you started our conversation today, Kevin, talking about, the importance of new ideas and new cultures. And I really think, as a person who loves and is really interested in naturalists and the land, like biodiversity and ecosystems strengthen those ecosystems. And I really think the biodiversity or the diversity in human understanding of culture is what strengthens us. It gives us new tools. I think we're challenged with some of the most difficult health crises that we've ever seen, and impending new disruptors like pandemics, and I think we new and old, I suppose, but I think it's really important that we look at this as an opportunity and an opportunity to strengthen us. And so medication appropriateness, how that looks from an Indigenous perspective is very different than Westernized perspectives. And I think that's what really strengthens this overall framework and looks at all of the structures in which health is delivered, from the laws, the standards, the institutions, the programs, and the healthcare providers themselves, and goes, how do we shift and transform that to create a balanced approach that includes a new and more diverse understanding of what health and healing is.
So I would love to hear more about the differences of the medication appropriateness. And is it prescription and non-prescription? Is it one side versus the other more so? Like, can you explain that a little bit further for just me not knowing, and just what might be the difference even for providers, like say that they want to start working more in Indigenous community, what would be so different for them if they were to make that shift?
I think that it's both Western medications where we're talking about inappropriateness and also traditional medicine. And so if we're thinking about the Western medicine side, part of it is about access, plain and simple. And so if you don't have access to healthcare professionals, if you don't have access to medications, as many folks in rural and remote areas of Canada do not, we don't have medication appropriateness. So that is one huge barrier when we're talking about medication appropriateness. The other thing is overuse, polypharmacy. And again, depending on who you're talking to, some of our elders grew up in systems where they weren't allowed to question. And so there's a definite sense for some folks that they can't question the authority of healthcare professionals in terms of saying, is this really something I should be on? And so there sometimes is a communication barrier in terms of even advocating for self in that sense. There's a lot of issues. Treaty and not upholding treaty rights and obligations as set out by the Crown before it was Canada is a huge problem, and I think could be a whole episode in and of itself, and not one that I can speak to very well. I'm not First Nations, I'm not covered by treaty. But ultimately, there's a responsibility by the Canadian government to be providing universal healthcare to Treaty First Nation folks. And that's not happening. From a traditional perspective, again, there should be integration of traditional medicine into our Western systems. And there's just no acknowledgement, privileging, or acceptance of that knowledge as being scientific, as being grounded in Indigenous science. And so there's just a lack of bringing that into our Western world. There's also hesitancy, though, in bringing it to our Western world because of the potential for misuse, misappropriation, commodification. And so, there's even barriers in that sense. So a lot of people have also been displaced from their connection to community and culture because of these colonial tactics. Like, look at me, I grew up in a very Western world because of that disconnect. And now I'm circling back, in my later years in terms of trying to gain that knowledge and understanding back. And so that's happened for a lot of folks too, in terms of medication appropriateness from a traditional medicine use perspective. Amy, what else do you have to say? I'm sure there's lots. See, this is a huge question.
Well, you nailed it. That's all the things. Well said, Amber. And I think the breadth and the complexity, you did a good job of explaining that. I think, what's like appropriate medication use means that a patient is empowered to understand and to navigate and be an advocate for their own health and their own well-being and that of their family and that of their community members. And that has been structurally and systemically disrupted in Canada. And for many Indigenous folks, there is ongoing prejudice and fears of engagement at a healthcare space. There is, as Amber indicated, some communication barriers, some understanding. I mean, medication and healthcare is complex enough. I think we would be remiss if we didn't acknowledge the complexities of misinformation, which I think has always inequitably harmed marginalized communities and continues to do so. And in the advent of social media, it's tough to say what we do and do not understand about our health. And so I really look at this as an opportunity to navigate the empowerment of all patients, to be stewards of their own health, but that comes back to healthcare providers being able to centralize and clarify the right types of resources. And many of those are community led and should be built on the values and the needs of the communities that they're working with. And ultimately, it really boils down to being able to form trusting relationships, both one-on-one, with entire systems and communities, and finally within the structures and with health is derived.
I think that's Well said by both of you in so many different ways of covering a very broad topic there. Here's a couple I want to dive into inside of that. We're all pharmacists here, and we talk about this word that's called adherence quite often. Right? I think adherence in general, when we're talking about decolonizing westernized medicine, is one of those things that I think needs to be tackled in many ways. Right? Here's this pill, and you will take it. What are your guys' thoughts there on how we evolve the Western medicine thinking of what shared decision making is and how we start educating? I've seen in several settings in the United States, we're trying to educate medical workforces on how to better listen, right? Not hear words, but truly listen to the stories that are being told by the elders that they're usually speaking to. And I think that shared decision making, the one thing for an individual that's not part of a culture that's very difficult is that to have a shared decision, you have to be on somewhat equal footing with each other to share that decision on a knowledge base and a respect kind of level. Where do you feel that needs to start? Where do you feel like we're at right now in Canada when it comes to making those shared decision processes and educating our healthcare providers and being able to even start that conversation?
That's a great question. And I have such a difficulty with the word adherence or compliance or non-compliance. And I feel like I've come a far ways, even in my thinking and my practice. I've charted those words myself, non-compliance. And it's really taken a lot of learning for me to step back and have that understanding of person-centered care. And I think that that's partly what we're working towards. I think partly as a profession, understanding what we need to do. And so not even looking at a patient, but looking at that person first and foremost. And so what are their values around medications? What are their values around health and well-being and their understanding of it? How do you open that door and have that conversation? How do you create that equity within that relationship? Those are all steps that we need to take as healthcare professionals to create that level playing field. And so people can be informed and willing to have those discussions with us about what's acceptable in terms of taking a medication and barriers that they might have. I think we often don't think enough about the barriers that people have in terms of medication use. And so it's really just a lot easier to use those words like non-compliance as opposed to really tackling the root of what might be happening with your person, your patient in front of you. And so that takes time and that takes energy and that takes learning, but it's certainly what needs to be done.
Yeah, I agree with that for sure. And I think sometimes this is where that diversifying of an understanding about the approach sometimes to healthcare, about what it looks like to create a safe space, what it looks like to create a safe relationship and a trusting relationship is something that can be rooted back in the lessons that we learn from Indigenous communities. The first thing that stuck out to me, the founder of the Indigenous Pharmacy Professionals of Canada did his doctorate thesis on Indigenous pharmacy professionals' experiences in pharmacy education. And one of the interviewees made this note about if I tell a patient a little bit about me in a reciprocal conversation, in a storytelling way, I'm being unprofessional. And I get a little slap on the wrist for that. And honestly, I've felt the same way. And I practice the way I practiced all along, which is, again, rooting myself first in the relationship with someone, better understanding who they are, because non-compliance has so many reasons. And most of those reasons can be navigated by first really understanding the person. And so, what's beautiful about the work that is done, I think, in authentic Indigenous engagement and diversifying our understanding of healthcare is that we start to reinforce the need for practice models that are really effective. When I talk to primary care pharmacists, they're like, yeah, I spend an hour with a patient, sometimes once a week if they're a new diabetic. And I was like, exactly. Exactly, because then we understand exactly what the fears and the challenges and the side effects. We see how it doesn't work within the environment in which that health is being delivered, whether they are having transient houselessness, which is going to impact their capacity to store or safely store those medications, whether or not they do have either spiritual or cultural barriers or fears, whether they have a preference or a privileging for something that would be other than what you have recommended, and how can you utilize your position as a health provider to help them navigate those decisions that are rooted in their own decisions. And I think COVID for me was a really good example of, like, we had a lot of people really afraid of what was like what we were calling first line therapy. Go get that vaccine, and they're calling it the jab, and they're saying that it injects AIDS and just crazy stuff. And to us, it was crazy, but for them, it was felt really real, and those people were really, really afraid. And so, in that fearful interaction, it's my responsibility not to ensure that they take that medication. It's actually my responsibility to help them navigate a really stressful and a really fearful experience. And as a person who's navigated my own diagnoses and those of my family, I mean, we have to look at that emotional and mental and spiritual well-being, and we need to be able to open up the conversations that says, like, do you have those supports, and who can I connect you with, and who in your community can be really an important part of this. And once that's established, and I look at you and you say, and go, geez, that blood pressure has been edging on 190 for quite some time now. And, there are some problems that are going to occur from that. And this is what my recommendation is. If you trusted me, would you go along this route? And maybe we will embed some other traditional medicines, and I'll connect you with folks, and I'll look up how that might interact with your regular drug therapy. And I'm going to help you in monitoring the safety and effectiveness of alternative or holistic forms of health and well-being. But all in all, know that I'm a part of your team, and the health vehicle that we're traveling along, you're in the driver's seat.
So when you are talking about some of these disease states, and going back to saying, when you said that the Indigenous peoples, they tend to live 19 years less than their Canadians, if you will. And what I'm curious about is there a specific disease state that they are more fearful of? Or is there, and I'm thinking in terms of deprescribing too, right? We talk about the deprescribing network, and we often see that deprescribing throughout the past, 20 years has been very medication specific at times, and what if we lower this, or what if we stop this met kind of thing. And they're the high hitters of the opioids and the anticonvulsants and and that type of medication, antipsychotics. So is there some kind of studies out there that show, this is a problem, and this is what needs to be addressed more so that we can increase this lifespan, and how do we culturally do this so that we can show that, maybe we do need more medicine, or maybe we need a little bit more healthcare in this particular area versus trying to take care of everything all at once.
I think what we find in these conversations is often you start to look at statistics, and then you see, okay, there's a higher percentage of Indigenous patients that have these conditions. And then we go, okay, is that, a clinical or a genetic factor? And the fact is that the prevalence of disease state inequity is associated first with social determinants of health, and we actually refer to colonization as a social determinant of health, and the major disruption that it was to all of those health factors that are rooted in which health is derived. And so that's part of it. Some of it is access to healthcare services and healthcare providers, folks having to fly in to urban centers to access care, not having consistent prescribers. And we often find that it's a cycle of locums that get sent out to Indigenous communities. And in that way, we're often just looking again at an issue and going, oh, brand new lens, I'm going to give you the symptom treatment. Brand new lens, I'm going to give you the symptom treatment, and not really diving into the root source of that healthcare, and even seeing, I think, sometimes the inefficacy of just the health space itself. Even the really well-intentioned and really invested health professional who understands the circumstances in which your health is derived can't fix the fact that there isn't clean drinking water in your community. Can't fix the fact that there is intergenerational and systemic poverty facing your community, or that there's no health foods or other aspects as well. And I think ultimately, when I look at, I think all populations of the world, our biggest crises are in mental health, and as an extension of that, the soothing and coping mechanisms of addictions to navigate the challenges of some of these social and structural harms. And that's where the real question for me is medication actually the most appropriate solution, or is community medicine, and is advocacy medicine, is culture and respect and collective experiences, are those the medicines that we should be funding and privileging? And that's where sometimes I feel, like I said, a little impotent as a health provider. And that's where I find myself now, is that even as a advocate for Indigenous-led pharmacy practice work, I still go, it's like, well, I feel like a lot of the questions or concerns that I have relate more to, the overall care and well-being of communities. And so that's kind of how I look at that. But there, you've indicated that there are problematic medicines, and often I think those are the ones that we choose to do that go, well, that's going to make that patient happy, and they'll walk out the door, and we'll have sort of solved something in the short term. But we really need to be cautious and careful, while still acknowledging that access is a critical feature. And I deal with that every day. Does the patient that lives in the remote community, and I'm providing them a prescription for Tylenol because they have some pain or they have a cold, am I giving them 30 tablets? Am I giving them 12 tablets? Am I increasing the risk of them having an overdose in the home, of overusing or harming themselves from that medication? Or am I creating barriers for them to have a medication that they need for symptomatic control? And ultimately, I think the true answer and the heart of that is did I have enough time, and was there enough built into my scope of practice and the structure in which I'm operating, that I could really empower that patient to understand how to safely use, store, and appropriately use those medications.
Amy and Amber, there's a story that I usually tell all of the young pharmacy students that ask me about like treating in Native American medicine and what it's like and what the differences are. And so I'll tell both of you guys that story, and I'd love to hear kind of your thoughts on it, and if you do some similar kind of conversations. I was a young student, and I was in the Indian Health Services in Yakima, Yakima Nation and Toppenish in particular. We had an individual come in and had blood glucose levels. Usually for all the audience, blood glucose levels around 100 is where you're kind of shooting for most normal patients that don't have diabetes. And those that do have diabetes, we're shooting for under 150 to 100, somewhere in that kind of ballpark range. This individual came in and her glucometer had several readings that were in the 60s. And she mentioned that she was feeling a little lightheaded and not great. And so as healthcare practitioners, we could have easily just we just need to change the insulin dosage, right? You can just change the insulin dosage, and now you got this patient taken care of. We didn't. The practitioner I was with, very respectful, knew this individual's family, knew her involvement in the community, and went deeper. And so then she revealed that she was going to the sweat lodge, and she was purposely pushing herself as low as possible because she was depressed about some decisions she was making. And then after she was done sweating, she would go on long walks to try to push her blood glucose levels even further. And so I feel like there's the difference, right? There's the difference between looking at a biological marker of saying, yep, that insulin level needs to change because that blood glucose is where it is, to getting to know someone as a human being and getting to see what they're doing on a regular basis to be able to take care of themselves, both physically, mentally, spiritually, and really taking care of that person on a holistic basis. So that's an example that I give oftentimes to young students, but I'd love from a I guess, the tradition of story that we have amongst our people. Do you use other similar stories amongst your students or folks you're working with?
That's a great question, because I think you're right. There's a huge power of storytelling, especially within our cultures. And I think that it's important in story, as you did, to highlight the emotional, mental, spiritual, and physical well-being, and to take that holistic approach, and how looking past just those biochemical markers, you see so much more about that person and how they really need to be treated as a person, and not just numbers. And so I would say that within teaching programs now, there is much more of a focus on trying to do just that. What else do you know about this person? What do you know about their values? What do you know about their sources of stress, about their sources of wellness? And trying to really integrate that mindset into teaching practices. And so I think that the more we do, the more holistic our practice will be. And so that will be just that much more fitting for our Indigenous patients and peoples. Amy?
I think it's certainly not just Indigenous communities now that are experiencing major health consequences, and I would say even like the epigenetic transfer of trauma, intergenerational, collective community trauma. And oftentimes those folks are being diagnosed with conditions like diabetes. They're being diagnosed with conditions that have impacted their hormone function, what is collectively called sort of neurodivergence. And I really like to share stories that I've completely, for what it's worth, made up, but I've made up based on the context of like how I understand human evolution and what it would have been like to live on the land through traumatic times, through difficult times, and how these adaptations that our bodies are making actually are intending to make us stronger. As a person who has polycystic ovarian syndrome, a bunch of hormonal condition changes, a lot, insulin function is a little funny. And when my insulin levels are really funny, I'm very much less likely to ovulate and to procreate. But I also, under stressful times, create a lot of extra testosterone. You may notice I have a lovely tenor in my voice. And, that makes me strong, right? If you would have dropped me in a war zone, I'm going to do pretty good. I'm able to efficiently utilize my glucose in stressful periods. I'm able to be strong and actually create anabolic steroids to navigate challenging times. I don't have a baby when it's a terrible time in the world. I have these mechanisms in place that are imparted resilience. And for those folks that are having trouble paying attention and having some of the mental consequences of ADHD, they're also folks that are really intuitive, really perceptive of their environments. And in a way, those are tools that we can use to wield in a positive way, and to wield in a way that actually makes us stronger, instead of feeling sometimes the hopelessness of, I am this, I can't change my trauma, I can't change my family trauma, I can't change my diagnosis. But there are tools, and there are holistic and lifestyle-based tools that I think that we can help in empowering patients. And so, often a little boy who gets this diagnosis for ADHD, and he's under 10 years old, and now he has to take a chronic medication. And I'm like, oh man, would you have ever been the strongest guy out on the land, eh? And they go, oh yeah, it's like, yeah, you can run and hunt, and you're busy minded, and you see everything, and you understand, and you learn so quickly. And yeah, no wonder it's hard for you to sit still, but that's okay. Mm-hmm. Like, you're really powerful, you're really strong, you're a really beautiful person. And I think that is the element of like this strengths-based work that we need to do for communities. And we had a brief conversation before we got rolling here today about, like, is it decolonization? Is it indigenization? It's definitely both. But the indigenization is, again, that really rooted strengthening, and putting ourselves in a position of knowing that we've encountered and navigated as societies, as peoples, as humankind, some of the hardest and best times in our in our collective experience. And it's just our chance to continue to evolve and to continue to reflect back on the strengths and ancestral and longstanding wisdom that has stood the test of time. And with humility and with some respect, try and find the way to adapt for that in a really contemporary space. And in particular, I think the spaces that we occupy, and for our cases, that's pharmacy practice.
Do you think there's a difference with whether it be Western medicine or holistic type of medications, or non-farm approaches, if you will? Does that matter for people, like to try something first versus second versus third? When you're seeing people, and I'm thinking not necessarily only the remote, but just culturally in general, does it take the Indigenous peoples long time to actually go seek help, because they're trying to take care of themselves within their communities? And is it just like a cultural thing, we'll take care of this, and then is it finally to a point where people are really sick? Or is it a kind of a mutual, more acceptable, if it's available and there's access? Yes. And does that matter on age of patient too?
That is a great question. And I think that we know that Indigenous people seek care farther along in their disease state or their illness. And I think that has less to do with belief in a Western healthcare system and more about feeling safe in accessing it. So we know when folks encounter our Western systems, they do face stereotypes and racism and poor treatment. And that, I think, is the reason that people are less willing to access our systems. And I think in terms of whether people want to use traditional medicine, Western medicine, non-pharmacological approaches is very individualized. I've spoken with some people who really would prefer to use traditional medicine first and foremost and only use Western medicine if necessary. Others who have belief in using both concurrently, depending on their teachings, and others who really do have a very firm belief in Western systems. So I think there's not a way to generalize across the board. And I think that each individual will come with different beliefs, and partly based on their own culture, partly based on what they've been taught, and partly based on their prior experiences with our systems.
Yeah. Who is the most trusted and accessible health provider in your circle? And if it's your grandmother, then it's going to be traditional medicines. And I think when we look at sometimes like plant-based, like there is a difference between plant-based and herbal medicines, although sometimes they are the same things. They are applied in different ways. And the natural medicines that can be used sort of at large. But I would say for natural or herbal vitamins, things like that, I think there is this interest that people have in caring for themselves. I'm one of them, where it's like, if I can deal with this without having to, I think, cross that boundary into asking for permission for something. And I think that, again, that's just a change in how we understand and how we navigate and recognize our healthcare providers. Am I going in there and, on hand and knee and asking, please, would you consider giving me a medicine? And then also not understanding or not having any say in that, as opposed to going in and having a conversation and really understanding what my options are and co-creating and co-developing a care plan for myself. That's a very different experience, and one that I've, started to experience more recently in conventional systems of care as I work with some of my primary care providers. But until that time, there is a power in being able to say, these are the things that I'm going to do for my well-being. And there is a difference sometimes in, I often say it's like, did you need to use a sledgehammer when a little finishing hammer would do? And that's a little bit, associated with the needs for natural or plant-based medicines, right, is a little bit more of a balancing as opposed to a suppressing or a very firm action. And so it just depends on the condition. But I think it really is rooted in, who is the source of access and who has guided you in your journey to help you understand and trust where health can and should be coming from.
And I would love to ask too that thinking about medication appropriateness, deprescribing, things such as that. And I know that there's a push, and there always has been, for lifestyle, right? And there's all these, lifestyle guidance, and how well is that embraced?
From Indigenous cultures, peoples generally, I think that we are getting to the point, I'm going to call lifestyle more along the lines of like reconnecting with culture, reconnecting with land, reconnecting with language. And to me, those are the lifestyle changes that Indigenous peoples are intentionally seeking out now. I grew up in the 80s, and I grew up with a lot of First Nations and Métis folks. And I don't think we understood how important culture was to us. I don't think we understood how important the teachings were, how important the land was. And I think a lot of Indigenous peoples now are recognizing how much healthier we would all be if we started the way that we are making style changes now. Did I just cut out for a second?
You did for a second.
Yeah, I agree. I honestly, when I think about lifestyle, I think, you have to be hydrated, you got to have enough fluid in the day, you need to eat a nutritious amount of food, you need to move, you need to rest, you need to quiet your mind, you need to connect and feel supported and emotionally supported, and you need to have some spiritual support. You need to be able to do all of those things in a day. And for me, I often looked at that, especially as a busy pharmacy student or something, being like, oh, good luck, like I need to add anything to my checklist of things to do. But that was for me like the big aha moment about culture. And that is what that ancestral wisdom comes from, is that was just part of our lives. It was part of how we engaged with each other. We see cultures across the world that embed that directly into what they do. There are folks that pray and they move and they do ways in which they pray that actually, get lymphatic drainage and blood flow to important organs and tissues like that. And I think it's just important to see that connectivity and that holistic understanding of health is really embedded in that. As much as many Indigenous peoples are recognizing and understanding the value of that now, many of our youth are challenged with, I think, the most powerful and dangerous distractions that have ever been made. We basically have a gambling machine on our phones now, and it's like lights and quick dopamine fixes. And we have elders that talk about, we do land-based activities with our youth, and they just go, I miss my phone, like I want to get back. And so I mean, there is a huge value, and there's a deep concern that that's going to be lost. And if we don't transfer that knowledge, it could be lost. And so we really have to look at this again from a very balanced approach, which is both embedding and strengthening and building that, but also creating the kind of protections from the harms and the very potent harms that can be, taking us away from that. And so we need to replace the good, but we also have to find ways to protect from and remove the bad. And I think that in so many ways is how we look at medication appropriateness as well. In Canada, marijuana is legal. And so I talk to a lot of patients about, their use of all sorts of things. And I'll often come down to is marijuana a medicine or a drug? And what's the difference, right? And is it, it's a drug maybe if you've used marijuana and then you eat a bunch of garbage and you sit on the couch and you don't do anything and you become very unmotivated. If it's something that reduces your pain and helps you stretch and move and get up off the couch and make a meal and take care of yourself, maybe then it's a medicine. And that's the same way that we look at pain medications and opiates and things like that. Is this something that is helping you to do all of those healthy rituals and engage with those holistic ways of becoming well? Or is it just something that's causing more harm than it is good? And that's only the type of conversation that you can have when you've really gotten to know somebody, and you understand what their values are, and maybe you're a familiar face embedded right within their community, who meets with their elders and has tea with them on Thursdays, and really shows in every way possible that you're stepping forward from a place that says, I am here as a tool for the community-led vision of health.
I love that both Amy and Amber have mentioned their elders. They've mentioned the community and family feel. The interesting thing, our title, right? Decolonizing, Indigenizing. When I think of modern medicine, Donna, I think you're going to send someone to see a stranger, a complete stranger that may be a different stranger next week, that's going to digitize and monetize your care. Native and Indigenous ways of healing couldn't be more opposite from that, right? What we've talked about today. Personalized, in-depth cultural connection with another human being that you know, trust, and value. And so my question really to Amy and Amber is, it would be wonderful. I mean, I would love to have my grandma back. But we can't all have our grandmas with us, right? Everywhere we go. We can't have them giving us our health needs, and it has to be passed down to the next generation for them to be able to take care of the needs of a community. And they have to be able to connect with that community on a deeper level. How do we start to take this modernized way of care, right? We're seeing some things happen like direct primary care, or something very popular in the US now. You're having individuals with a subscription pattern. You're seeing another individual, they're a text message away. There's more of a connection between them. But how do we actually get to the point where we can say we've gone back to a more native way of healing?
I think it starts with creating those relationships. The reason that we talk to our cookums, our nanaks, are because we have relationship with them. And that relationship is rooted in trust. It's really rooted in respect. It's rooted in that relationality, that reciprocity within the relationship. And so that's where we have to start. We have to start with learning how, as healthcare professionals, we create and maintain and nurture relationships with our patients. I don't really even know how to expand on that, because I think that it sounds so simple. It's not. We have all sorts of barriers to what we call relationship building. We talk about time. We talk about how busy we are. We talk about pharmacies often being a business, and so you're trying to balance all of those things. And so it sounds really simple, and I recognize that in the context it's not, but that's really what it comes down to: building relationships.
I've been reflecting on this quite a bit, and I think there's a certain amount that needs to be given back to people. That there's a certain amount of empowerment that needs to be given back to the people. And, I think about models like Alcoholics Anonymous, and, you have a group of people sharing their experiences who have tools, have like a very standardized set of tools in navigating a disease. I think patient groups and empowering patient groups is a really interesting way of doing that. We've had conversations with Indigenous and community or cultural navigators or facilitators or bridging folks within those systems who can be a continuity of that relationship. Because again, hearing and understanding and translating that story, ideally it is the doctor or the pharmacist, but in the models of care that we have, it may not be. But we do have to create space for those who can immediately take that on, who don't have the barriers of having to leave their community and pay for and attend 4 years of very difficult or 7 years of very difficult pharmacy or physician or nurse practitioner or any other type of provider training. I really think it's about empowering that back. And that's what's I think inspiring about the work that Caden is doing as a pan-Canadian organization, and looking at the type of tools that they create, not just for health providers, but for patients themselves. And I would go further into saying that, ideally for me, it's not just a PDF and it's not just a website. It's actually empowering and building in predictable and sustainable funding to create community-led movements around wellness and around well-being. It is the culture of well-being, and that will allow folks to be well-informed and educated and empowered enough to make those decisions, to know who to ask, to know when they need to seek that clinical support, and also know how to be able to say, you know what, I don't think that the way that you're treating me is right. And I'm going to get a second opinion, or I'm going to speak to somebody about the experience that I've had today. That to me is, I think, the real root of it is it's at the heart. Healthcare and health and well-being starts with us as individuals, and so much of that, particularly that community-based care, was disrupted by systems of colonization in Canada and many other places. And as healthcare professionals and those that are privileged to have voices in the spaces that are evolving these systems, we have to be able to say that we're not always the best person to heal communities. And when we can do that, and when we can create funding and structures that surround that, I think then we'll start to see the change that we need.
Love it. That was fantastic. Donna, any other questions for our wonderful guests?
Yeah, no, I just want to say thank you so much for being here and sharing the experience, if you will. I learned a lot tonight, so thank you so much. And I think we all have more to do, right? I think the patient-centered care model might be the right thing that we're headed towards to help people, no matter what communities they're in and what their needs are. I think listening to patients is just so important, and we really make certain that access and that people are there for the right reason, and that people are able to access pharmacists and providers in general. So important, and I think we are all needing to rethink healthcare and how we deliver it.
Love it. That's perfect. And I love that Amy and Amber, you guys were able to join us. Thank you so much for both of your time. I really appreciate your wisdom, along the way. And the fact that you both ended on, I think, real highlights for anybody that knows Native American healthcare or Indigenous care, looking at relationship building from Amber and the way that she really pushed for us needing to cultivate that in a new way. And Amy, you really leaning on, we need an intermingled or a woven healthcare team, that understands the aspects of the current dichotomy of healthcare and the cultural aspects of building that community, back up again. I appreciate those perspectives. So audience that was listening, thank you so much for your time. Any questions, please go our direction. We'll put links to be able to follow Amy and Amber as they go, and to Caden and some of the other groups that they lead. And I want to once again thank you both so much for enjoying this evening with us. Have a great night.
Bye, everyone.